The first question, the most important question is, do I have enough patient demand to fill that associate schedule? That could come from a big backlog, say 10, 15, 20, even 30 days of backlog for patients to get in, and you want to add doctor time to the office so your patients can come to you in a timely fashion and not decide to go somewhere else. The second place that patient demand could come from is you could decide that I want to work less. And so you'll be taking yourself out of the schedule and giving your patients to your new associate. The second real important question is, does the profitability of the practice support another doctor? In other words, if you're paying this associate out of your income, which is what you're effectively doing, is there enough either backlog so that the associate will pay for themselves, or if you're taking yourself out of the schedule, is there enough profitability for you to maintain an acceptable income after paying a new doctor to see patients? And a third question that a lot of people forget is, do you have enough space in your office to have two doctors working side by side if that's going to be the case? I advise doctors when they're hiring a new associate to judge the associate's performance on two metrics. The first and the most important metric is, what is the revenue per patient that associate's generating? They generally don't have a full patient load at first, so it's the best way to know if they're recommending products well, if they're billing correctly for their new patients. The second metric, especially for new doctors, is to judge them on how many patients a day they can see. So as you fill up their schedule, are they able to see 16, 18, 20, 24 patients a day and not stuck at the 12 to 14 patients a day level? You really want to keep the associate schedule full. If you're paying them to be there, which you are, you want to make sure they're seeing a full patient load so you're getting your money's worth. There are three basic ways that associates get compensated. First off, you can pay them an hourly rate, and that works fine for associates that may be there 1 or 2 days a week. Also, a per diem is a common way to do it. You can pay them on a straight salary, so say fix their wage at $90,000, $100,000, $120,000 a year for a full-time associate. Or you can pay them on production. In Prima, almost always we're going to recommend that you pay either a per diem or a fixed salary to your associates. There's a lot of advantages to this to both parties. For the associate, it takes the risk out that if I'm paid on production and I don't have a full schedule, how am I going to make any money? So you take the risk away from the associate on the downside. For the practice owner, there's a lot of benefit to having a very predictable cost to your associate doctor. And also, as they get busier and start to produce more, your profitability on their production will go up. Now, many practice owners feel like they need to pay their associates on production in order to have the associate produce at a high level. My experience is that just isn't the case. Many associates are very happy to be paid a solid, good wage and take care of patients at a high level. But the one time I do recommend paying associates on production is if you have a very productive associate who's building up his or her own book of patients. Paying them on production is a great way to reward them for their contributions to the practice without giving them equity and having them buy in.